Hello, everybody. This is Kelly Williams. I'm from the Medical University of South Carolina and an ECI committee member. I just want to welcome you to our CIS Case Conference webinar. Jude and I will be moderating to two different cases today. You get the pleasure of me also presenting because I think I couldn't find another presenter, so we're always, as ECI members, looking for people to present interesting cases. So if you have one, just let any ECI clinic committee member know, and we'd be happy to have you present at one of our webinars in the future. So I just want to thank USID Net and LACID sponsors for our webinar today, and then just go over a few quick things. If you have questions, you can post them in the attendee chat, which is at the top of the screen. If you're, you can also mute your microphone, or if you're on the phone, you can mute that as well. And then one last reminder to register for our upcoming annual CIS meeting if you haven't already. Okay, so my presentation is really another look at complement deficiency, and kind of just thinking what came first in the clinical presentation. So this child was a 16-year-old African-American male who presented to a local emergency department from Myrtle Beach, actually, so 2.5 hours away or so. But he presented with a high fever, malaise, and productive cough. His chest x-ray was proven to show left lower lobe pneumonia, and he was treated with outpatient oral antibiotics for 10 days and clinically improved. So that was his first serious infection. He had some normal number of colds before that, but no real serious illnesses. After that illness, he presented again to his primary care doctor 2 months later. He had recurrent headaches, sinus pressure, periorbital edema, some blurry vision, and fever again. And he was diagnosed with acute sinusitis and treated with 5 days of azithromycin. And then 1 month later, he presented to the ED, again with fever, this time with shortness of breath and chest pain, rib pain, and productive cough. In the emergency department, he actually clinically decompensated. He became hypoxic and had increased workup breathing. A chest x-ray was done, showed some bilateral effusions and diffuse opacities. He ended up going to the PICU and requiring pressor support. He required BiPAP for his hypoxia. He ended up needing a thoracentesis. He ended up needing some blood. And then he required some significant diuresis through all that. From an infection standpoint, he was diagnosed with GBS sepsis and pneumonia. And then he was hospitalized, I think, for like 10 or 11 days. He ended up doing, walking out of the hospital pretty much the same as he had been a month prior. He was doing much better. But he followed up a week later and kind of just felt crummy again. His primary care doctor did some blood work and he found him to have anemia, some hypoalbuminemia, fatigue, and weakness. And they also noted that he had some hyperpigmentation on his back and then his nasal bridge. So he also followed up again and ended up having some knee pain, lower leg pain, no joint swelling, no warmth, no stiffness. He was referred to immunology because of the concern of an unusual organism for sepsis at his age, GBS sepsis at age 16 with no prior infections. So when I saw him, he had a past medical history that was pretty benign. He was pretty healthy. He had some recurrent strep as a child. It warranted a TNA, and then he had resolution completely. He had a few colds a year, but nothing prolonged. He had no history of other pulmonary infections, no fungal infections, no skin infections, no cutaneous viral infections or meningitis or osteo. And then the only other thing that was of relevance was that he had iron deficiency anemia around age 10 that was diagnosed and was on some iron. He had no family history of immune deficiency or severe or recurrent infections. He had no history of early childhood death in his family and no history of leukemia, lymphoma, or IBD. Mom carried a diagnosis of lupus. Dad had some history of needing a muscle biopsy, but nothing else that was significant. And they said the biopsy was normal. So I saw him initially and noted him to have anemia with a normal MCV. No other, his white count was fine at the time. His platelets were fine. And he had, again, hypoalbuminemia, 3.1. He had an elevated SED rate with a normal CRP. He had some significant lymphopenia that was noted, both from a CD4 and CD56. Oh, there's a question. And then normal immunoglobulins, normal titers. And his CH50 was low. And then I repeated it and it was 0. Or 5 is essentially nothing as well. And then AH50 was low and undetected both times when that was repeated as well. His MBL.
I think someone is asking what is GBS. I think you mean a gram-positive or
no, group B.
Group B.
A group B streptococcus. Okay.
Yeah. So normally when group B strep sepsis, I see more in like neonates, if anything. So an unusual organism for somebody to have at that age. Was there another question?
No, they were just saying thanks.
Oh, okay. Sorry. And then, so obviously the initial complement screens were pretty abnormal, and so that warranted a little bit further evaluation. I don't know how many people typically do. I usually just start with actually CH50, and then I ended up doing an AH50 just because I thought GBS was a little unusual. And then when they both came back low, I repeated them because I was worried about samples sitting a little bit too long. His C3 and C4 were also low, quite low, but not undetectable. And that prompted a little bit further evaluation. Sorry, so these labs I actually didn't do all at the same time, but kind of in sequential order. I guess there's no animation, so I can't do them in subsequent areas. But then after the C3, C4 were also low, I wanted to evaluate for, I think the alternate pathway defect was a little bit more concerning for me at the time, just with his history too. So I did the factor I and factor H. And then sent for terminal complement labs, and those were all low in the terminal complement. Those were done at National Jewish, and then factor H and I also done National Jewish was elevated and then normal.
Kelly, if you could just stop for a second. This is Jordan.
Yep.
I was just wondering if I could survey the attendees here to see how many routinely send AH50 when they're doing a complement workup, just out of my own curiosity. I don't know if anyone can. Everyone's
Yeah,
muted.
I think they could probably answer by attendee chat. Let me see. Someone said, Jude said very rarely. I do not typically do AH50. And yes. Most people say never, not usually. Yeah, so not rare, not often. So I think I did it initially. So I always in my initial screen do CH50, but because I was worried about a really unusual organism that kind of came out of nowhere, and so I sent an AH50, and he also lives 2.5 hours away. I sent an AH50 the very first time, and then when they were both very low, I obviously repeated them. But yeah, It says,
I mean,
would
I
if I
think
could.
there is some utility to sending if you're worried about a deficiency in a specific component of the complement cascade, because it'll help you differentiate between a terminal pathway defect and one that would be in the classical pathway.
Mm-hmm.
So it's reasonable, but it is not widely available. We do it at National Jewish, but the samples do need to be processed properly.
Yeah. I mean, I guess I wonder also, as a follow-up question to that, how many people like really either get in fights with their lab or really have to strongly ask for their samples to be processed appropriately. Because sometimes I have to get a CH50 3 times before like I'm like, really, this should be normal. Like they're there for something else, you know, but their CH50 keeps coming back borderline low. Yeah, okay. It's really sad sometimes.
So yeah, why don't you continue on?
Sure. So because the AH50 was so low or undetectable is why I ended up ordering the factor H and factor I, because normally I was like, oh, great. Like normally that's not, both are not so abnormal. And so I ordered those to look for other defects along that pathway and was reassured that they were normal or mildly elevated. And so then I was still trying to figure out where exactly the pathway would be. You know, obviously C3 is a big central activation center, and was looking to see if this is really a production deficiency or a consumption process. And that's why I sent further labs looking at the, consumption byproducts. And so I think this is where I got a little bit stumped. It's mainly because I was, when I'm asking a question, is it consumption or is it production problems? And I would have thought, I think, that with consumptive process that I should have had some elevation in these other breakdown products, but that was completely normal. So I didn't really get the answer that I was hoping for there. I don't know how many people usually have it more clear, but I really was trying to find it a kind of a reason of where my losses are. Anyway, so those were normal. So then I just put this, oh yes, boys for proparatin deficiency, X-linked. That 100% was on my mind as well. And, National Jewish has a nice panel, but the proparatin assay has been down or was down for like 4 to 6 months because during my evaluation, I just kept getting reports saying that the assay was down. So I put this there. Sorry, I thought there was animation. So I had 2 different pathways. One was the typical pathway, and that's behind here just to kind of show the alternative pathway and kind of, I can't change it, and to show where the IC3B and the C3A are. But then I put a second image over it, kind of just showing from a clinical standpoint what we're supposed to think about when we think about different deficiencies, whether it's renal disease, whether it's actually intrinsic, whether they're sick with meningitis, or they just have autoimmunity. And I think this, I tried to put there to highlight when we go down each of these different pathways. And this child really had a defect really around C3, which is where they all come together. So I was sitting there puzzled a little bit about some of his C3 deficiency aspect, and obviously with his joint pains, they evolved. His hyperpigmentation was definitely not like a malar rash, and he was African American, so it was really like it really looked a little just more bruised or dark. But anyway, I said an ANA and with a reflex of an ENA, which came back quite abnormal. And he had pretty elevated anti-double-stranded DNA antibodies, as well as Smith, SSA, RNP, anti-chromatin. And so he ultimately led to a diagnosis of lupus. And his his diagnosis of lupus kind of evolved, and he ended up also at the time when he saw rheumatology having an abnormal UA, which I did not send initially on my evaluation because he had no symptoms and I wasn't there. And I was focused on all his other abnormalities. And so this table I put here is just kind of the evolution of things. So I was following his C3 and C4, which continued to be abnormal. By the time he got in with rheumatology and a diagnosis, he had a significant flare initially. And just to put it into context, this October 2016, all of his GBS sepsis and everything was almost a year before that. Or it was like maybe January. And so he got sick with all of these things and then continued to have a clinical presentation that evolved into lupus. And so I was doing my immune evaluation, and then rheumatology was doing their evaluation eventually. And I think I was just focused on the immune stuff, and it eventually took a step back and realized some of the rheumatologic things, and we ultimately ended up with our diagnosis. Anyway, I put this table here because I wanted to show a conversation that was a perpetual and has been a perpetual conversation between me and rheumatology. Is really they continue. I'm blaming the lupus on his clinical picture and his infections, and rheumatology's notes continue to just say, oh, he has an underlying C3 deficiency that really was unlike when he had his lupus flare. And they've used pretty much this table as their justification to show he continues. He has no budge in his C3. But his lupus is under control and his antibodies are under control, but his complements still suck. It's basically why they think that he also may have an underlying C3 deficiency.
Kelli, you got a couple of questions. One of them, sure. Do you know during the time when he was in the PICU, did he have a urine analysis?
Yeah, so I don't know that. I don't know that. He was not in our hospital. But that is an excellent question. But he was also quite sick, so I don't know. I mean, he had hypobulimia, so probably they did assume he had urine losses and just kind of chalked it up to that. But I don't know for sure.
Okay.
But that's an excellent question. Could this have been detected earlier?
Right. The second question was how high his citrate rate reached.
It was like no higher than I think 72. It was 60 when I saw him, but it was 60s, 70s. I mean, now it was very quickly 30s and less, but in the very beginning when I saw him, it was 60. But his CRP was normal, so I was like, oh, it's not infection right now. And I wasn't he didn't have joint pains the first time I saw him. Anyway, so eventually his clinical picture evolved. He ended up getting a kidney biopsy because of his abnormal urine protein to creatinine ratio. And this was class 5 lupus nephritis. And so then rheumatology and I continued to have this ongoing conversation about who's blaming which area for his abnormalities. And then we looked at, after talking to some of the Jordan at National Jewish, I was trying to say, well, his consumption products weren't elevated, so I can't clearly show them that it is consumption, but intrinsically his kidney biopsy on immunofluorescence did show C3. And so that's a good indicator of the fact that, well, he has enough C3 that we are seeing it in the pathology that it's probably not truly a deficiency. Did he have a C3 nephritic factor? No. I did not do that.
Another, I think, finding that would not support a C3 deficiency is the consumption of the terminal pathway products. C5 through 9, I think you showed that on a few slides ago. Right.
So a question about that actually, because I've read that, if you have if you have a true C3 deficiency and it's really low, then obviously you're going to have still terminal defect stuff, or you can.
You can't. You wouldn't be able to activate the terminal pathway.
Oh, okay. So, okay, sorry.
If you're completely deficient.
But then you would still have low.
You should have normal levels, maybe even elevated.
Okay.
Some of them are acute phase reactants. So the finding that you have a consumption that extends all the way to the terminal pathway suggests that it's being activated.
Okay.
And it must be going through C3.
Okay. So moving on, the clinical stuff is pretty straightforward. For his lupus nephritis, he was treated with high-dose Solumedrol, and then he was on prednisone for a good half the year. Now he's just managed on MMF and Plaquenil, and he's done very well. Before all of this, I vaccinated him with Pneumovax, and then he got his meningococcal vaccine, and started him on PenVK. Which I think it was interesting because when I had the conversation with him, I basically said, until you have no clear function from either of these aspects, so that both the alternate pathway and the complement pathway, the classic pathway, seem to be affected from the consumption standpoint, but still you don't have enough and you're at risk for infection, specifically with deficits in the terminal pathway and putting him at high risk for meningitis. But when during one hospitalization, somebody had mentioned to him that this PenVK prophylaxis might be short term, and then we also had a long conversation. So right now, so basically the parents and the child, he's a teenager, so he wants less is more for him, and so he would love to get off antibiotics, and so. I read some of the data about switching to monthly bicillin, and I have considered it many times, but I have not yet made the jump just because I don't really know. There's only, I think, 1 or 2 studies that show it, and they both were small. So I don't know how many people actually do that in complement deficiency. And so I was hoping maybe we could talk about that. He's done very well on PenVK. He's literally not sick, except for a cold here or there. Did anybody do monthly bicillin? Hello?
Does anyone have patients on penicillin VK prophylaxis?
I think you got one answer as a no.
Okay.
And you actually got
complement levels have not normalized. This kid is on treatment and has continued to have C3 in the 40s at best, and I think his C4 was. I just saw him 5, no higher than that. He still has, and his terminal levels are still low.
And Kelly, you got a question from Troy. He's asking, did you say C3 nephritic factor was not checked, or was it checked and it was negative?
It was not checked.
No, I think it's possible that a nephritic factor is present, but the biopsy picture is most consistent with lupus nephritis.
Yeah, exactly. So I did go down and look at the slides, and I specifically asked them, are we sure that this is really truly lupus nephritis versus membranoproliferative? And they laughed at me and said there's nothing consistent at all about other glomerulonephritis C3. They thought it was very much consistent with lupus nephritis. Both the nephrologist and the pathologist agreed with that. I did not check a C2 level, which I guess 100% I probably should do, since we know C2 is also associated with lupus. Interesting, mom who also has lupus has normal complement levels. That has been evaluated.
You got a question whether you offered meningitis B vaccine.
Yeah, he was vaccinated early before. I vaccinated him before, like after his AH50 and his CH50 were low.
Yeah.
I will definitely do that. So, question for people: if his C3 nephritic factor is positive, though, does that change your decision for what? Penicillin prophylaxis? No, his terminal complements still are low. I guess how would that change my day-to-day management, except the education and prognosis? But I will do that.
Kelly, you got a couple of other questions. One is saying, with mother and son affected, do you think that this is a monogenic lupus syndrome?
I'm not sure. I mean, I think that's a very good possibility. I know that our rheumatologists have collected blood from mom as well, so I can follow up on that.
Okay. There are some other questions to follow. One is, do you consider this a primary C3 deficiency?
So I think that the renal biopsy was really helpful in differentiating that this isn't primary, because we have, if it's true primary, it should be much lower and probably not detectable in the kidney biopsy. But it was noted in the immunofluorescence of the kidney biopsies, and the levels are low but moderate. So I think it speaks against that, which is why I think it seems more consistent with a consumptive process. And then I guess the question about C3 greater than 40 usually doesn't predispose to infection is probably true, but the reason I have him on PEN-VK is more because his entire complement terminal pathway is all low. Yeah.
So you got another question in the same line, is saying that, so how do you explain the pan-hypocomplementemia? Is it consumption, and what would be the explanation?
Yeah, so I think that's an excellent point as well. I see a lot of lupus kids who all have pancytopenia for the most part. Especially when I first saw him, his numbers have come up a little bit with his now that he's not out of the acute flare. When I first saw him, and his function is normal for his lymphocytes. I didn't put that in there because most of the conversations focused on the complement stuff. But he definitely continues to have, low CD4 counts and low, his NK cells are like borderline low, high 80s. But they've come up since his lupus has been under control, but he still remained to be on the lower side. His hemoglobin as well, and his other cell counts are okay. And I think that's one conversation, though. Like, whenever I've had these conversations with rheumatology and they want to blame his immune system and I want to blame his lupus, the conversation continues to go, well, if it's his lupus and his lupus is under control, why does his numbers never get better? Because even when they show that his, and maybe Troy, you can add in since from your rheum background, but even when his anti-double-stranded DNA gets so much better, his complement levels change nothing. And their suggestion is, we're showing his lupus is under control. Why is his consumption not under control or better?
Right. There is a comment from Troy to consider the use of rituximab if there is a C3 nephritic factor, and in general, it's a reasonably good drug to treat lupus.
Yeah, our rheumatologists do love rituximab, actually. But I think that their concerns were more from if we can get his disease under control with less, then we can see how he does, because he responded really well just to this Solumedrol. And since I'm not sure I've really convinced them he doesn't have an underlying immune deficiency, I think they're more understanding at this point, but they're less excited about tanking the one cell line that he has that's pretty normal. But we've had the conversation about Rituxan, but we did not have the conversation with the concept of a C3 nephritic factor. So I will look for that and talk to them about that. That's great
And
insight.
I think the last question, could this all be due to primary C2 deficiency, which can be hereditary, and would you expect a different presentation?
I can't answer the question about a different presentation, but I think definitely it very well could be hereditary with his mom, even though I know that she has normal complement levels. Yeah.
Okay, I think there was one last question. Whether would you consider genetic testing for him?
Yeah, so I definitely considered it, especially after I got my normal C3A or the consumptive things and IC3B. But I kind of felt like when I found that in the kidney biopsy that there was detectable complement, I mean, I guess the question for genetic stuff, if I look for C2 or other things, that is reasonable. But to look for a further genetic evaluation of his C3, I felt like his C3 was mostly more consumption. So I kind of stopped with or decided not to do genetic stuff. But if other people think that there's strong yield in that, I can reconsider that.
Well, that was really excellent. We don't get to talk about complement deficiency that much, so I think that was a great refresher and great discussion. I think we gotta stop here to allow enough time for the second presentation.
Great. Well,
thank you so much, Kelli. Okay, well, that was great, and we have a second great case that will be presented. Our very own fellow, Dr. Naty Chaimowitz. She is a first-year fellow at Texas Children's Hospital in Houston, and Dr. Troy Torgerson from University of Washington in Seattle will be joining us as well. Naty will be presenting a case of a curious case of IPEX versus IPEX-like disease. Naty, take it away.
Thank you for the introduction and for allowing me to share this interesting case. So this patient was a transfer from another hospital. He presented there at 1 month of age with failure to thrive. At 1 month, wasn't yet back to birth weight, and mom reported that he had had ongoing diarrhea since birth. His newborn screen was normal ×2, and despite adequate nutrition at the outside hospital, he continued to not gain weight. He was also noted to have thrombocytopenia and anemia, requiring transfusions throughout admission, and his stool output worsened throughout his admission. Family history was really non-contributory. There was no GI issues or history of immunodeficiency, and he lived with mother, 3-year-old sister, and 12-year-old brother. They were all healthy, and dad was not involved in his life. Very notable things on exam when we first met him is he was very thin with little subcutaneous fat. He was very cachectic appearing. His liver was palpable 2 centimeters below the costal margin, and he had diffusely dry skin, but his exam was otherwise normal. So in the outside hospital, they did a very thorough workup for his failure to thrive. He had a normal TSH and free T4. They evaluated for renal tubular acidosis with a renal ultrasound, and then urinary studies that were normal. And they did note that he had 1 to 2 plus proteinuria. He had an echo that showed an ASD, but normal function, a normal CMA. Infectious studies were all negative. Their immunology workup was significant for a highly elevated IgE in 1710. He had normal lymphocyte count, normal subsets, and normal oxidative burst, and his absolute eosinophil count peaked at around 1200. Because of his ongoing diarrhea, ultimately they did a scope that was significant for bilious blunting and intraepithelial lymphocytosis that was concerning for autoimmune enteropathy. And when it was reviewed, Texas Children's pathology comment on the extraordinary amount of inflammation that was in the gut. Fecal calprotectin was also markedly elevated, and enterocyte antibodies were sent and were pending at time of transfer. So for us first meeting him, we felt that the differential was very broad, so we proceeded with whole exome sequencing. Unfortunately, because that wasn't involved in the picture, we were able to do a proband whole exome sequencing instead of a trio. We repeated lymphocyte studies, and they were normal. His neutrophil oxidative burst was also normal. His IgE continued to be elevated. His dual alpha-1 antitrypsin was markedly elevated, consistent with protein-losing enteropathy, and his soluble IL-2 receptor alpha was also elevated. On repeat, his TSH was very high with a very low free T4, consistent with hypothyroidism, although he didn't have any thyroid antibodies. So I just want to pause and see if anybody has any questions or any thoughts.
So the first question was his IgG decreased?
So when we first met him, his IgG was normal, but in repeat checks, he had a very low IgG secondary to his protein-losing enteropathy. And I'll talk about the management in a little bit, but he's actually on daily IVIG to keep his levels therapeutic or protective.
So maybe at this point we can start asking the audience about their thoughts. And we mentioned that we have a broad differential, but maybe we can talk about like the top things that people are thinking about. So you have a question. Hyper IgE CD40 ligand deficiency. Was protein normal? I think that's the question.
We look for WAS protein. We didn't look specifically for STAT3 mutations or CD40 ligand or anything like that. We were waiting on whole exome sequencing, but it's something that crossed our mind as well.
Did you consider celiac disease?
We discussed it with the pathologist, being that there was bilious blunting, but they said that the degree of lymphocyte infiltrate in the path specimen really was not consistent with something like celiac, and it was much more suggestive of autoimmune enteropathy.
You have one more question. Did he have any evidence of candida or oral thrush?
No, he did not, and he hasn't at all. So the title of the talk gives it a little bit away, but the next thing we also sent for FOXP3 expression, and this is from the lab in Cincinnati, and the top is a control, and then the bottom is our patient. And what you can see in the red box is that out of the Tregs and the control, 82% of them express FOXP3, but our patient had at most 5%, but very, very little expression. You could say he didn't really have FOXP3 expression by flow. With this, we basically made a clinical diagnosis of IPEX. IPEX is immune dysregulation, polyendocrinopathy, enteropathy, X-linked syndrome, and FOXP3 is important for the development of Tregs, and in the absence of Tregs, you have your T cells being skewed towards a Th2 T cell, so you can see eosinophilia, elevated IgE. You also get autoantibody production. You can get gut disease, an enteropathy like our patient has. Often there's type 1 diabetes, and while our patient doesn't have type 1 diabetes, he does have zinc transporter 8 autoantibodies present. They also Patients with IPEX also get very severe dermatitis, like our patient. They get autoimmune thyroid disease, and they can also have kidney involvement. And while we don't know the extent of kidney disease in our patient, he has persistent proteinuria. So this is a really busy slide talking about how we treated our patients. So throughout his admission, things that we monitor were his mixed stool output in blue. We also monitor his white blood count because he had a very coarse and very high elevated white blood count that was neutrophilic predominance. So at the time of transfer, the patient was on Solumedrol, 1 mg per kg BID, and that's something that we continue through admission. He also had intermittent fevers with no infectious source. So initially, we started the patient on tacrolimus drip, but we had a really hard time getting therapeutic levels. At around that time, his albumin was 0.6, and tacro is mostly protein bound, so we felt that it was really difficult to assess levels with such a low albumin. He then developed bloody stools, which is not something that he'd had in the outside hospital, but from that point on, continued to have intermittent bloody stools. Because of the difficulty with therapeutic levels on tacro, we transitioned him to cyclosporin, and then we also started him on daily IVIG. There's evidence that enteral IVIG is helpful in the setting of viral infections of the gut, but we started him on enteral IVIG, hoping that it would help his autoimmune enteropathy. Much to our surprise, when we received the FOXP3 gene sequencing, there were no mutations, deletions, or duplications. So at that point, we said, well, clinically he really fits IPEX, but maybe we'll be surprised what his whole exome sequencing shows. He continued to have large stool output, so he also received pulse steroids, and we added sirolimus. While on sirolimus and cyclosporin, he developed hypertensive emergency requiring transfer to the PICU. So at that point, cyclosporin was stopped, and we gave him a trial of abatacept, rationalizing that we know that our patient has few Tregs, and Tregs express high levels of CTLA-4, so maybe CTLA-4, abatacept, CTLA-4 fusion protein would be helpful in his case.
So, Naty, you got some questions here that we probably could tackle before you move on. So the first question was, were there any history of allergy or atopy?
As far as family history, there was no family history of allergy or atopic disease. The patient did have very significant eczema-like rash that was diffuse, and that improved once he was started on tacro, and it basically resolved.
And then kind of some of the audience started giving you some other possibilities, including STAT5B deficiency, CTLA-4, LRBA deficiency. One question was, were there plasma cells seen in his pathology from the gut?
I think that the pathology report did mention plasma cells, but that wasn't what was very impressive to the pathologist. It was really this lymphocytic infiltrate that they noted. I think the differential that people are offering is many of the things that we had in mind. By the time we got the FOXP3 gene analysis back, we were just a few weeks away from getting whole exome sequencing results. So we didn't send any additional single gene testing or any more phenotyping.
Okay, and then one question, I think it was meant, was there a change in the FOXP3 expression when you mentioned that it was repeated?
No, I continue to be low.
Okay, and then thymic output studies?
We didn't do those. I'll tell you that when we first got lymphocyte studies, they were normal. And once we started him on sirolimus, he is very, very lymphopenic. So getting any additional studies to understand what his T-cell compartment looks like is challenging.
Okay. One question, was FOXP3 expression checked on the biopsy specimen also? Just out of curiosity, as sometimes it differs from the peripheral blood.
We haven't done that, but that's a really great point. And I'll be curious to know more when you see that discrepancy between the tissue and the periphery.
There is one other question about possible maternal engraftment.
We didn't do the test, but we thought about it because initially in his phenotyping, he had an inverted RO to RA ratio, but when we repeated the phenotyping, it had normalized, so we didn't pursue that farther.
And this child was born in Texas, right? So,
yes, and he had 2 newborn screens that were normal.
Okay. So there is a comment that if his newborn screen was normal, then he probably had good thymic output. Sorry, go ahead, Troy.
Oh, I was just going to say, so, the FOXP3 testing, I'm assuming, was not done on any activated peripheral T cells because it was just done on resting cells, as far as you know, right?
It's based on this gating of looking at the CD25 bright, CD127 low, so I'm assuming yes.
Yeah. But I'm assuming that they didn't do any additional T cell activation before looking at that. The reason I ask is that there are missense mutations that in FOXP3 that don't allow really generation of regulatory T cells. But then if you take peripheral T cells and you activate them, about a third of them will transiently express FOXP3, and so you can, if there's protein that can be made, you can see it. It'll come up transiently, and then it'll disappear if you remove the activation. So that was my question. Most clinical labs don't do it on activated samples. It's just on resting samples. But it can tell you whether or not there's a defect that is somewhere outside of the coding region of the gene that you might not necessarily, that makes it so there's no protein expression, but you wouldn't necessarily pick up using normal sequencing approaches.
Yeah, I have the whole report that I can look at, and then I can always email the lab and ask to clarify that question. So here is our patient's growth chart. He was born at 8.5 pounds. By the time he transferred to us, he was 7.5 pounds. And at 5 months of age, he weighed 10.5 pounds. So although he's gained weight since the time of the transfer, he continues to be severely malnourished. So we got the whole exome sequencing, and it was interesting for sure. So the pathogenic variant that the patient has is in the spectrin-1 gene, and this gene is known to cause elliptocytosis. So while this might explain his hemolytic anemia, it certainly doesn't explain the rest of his presentation. The patient also had 2 mutations in COG6, and COG6 is one of the components of the Golgi complex that's important for glycosylation. What we don't know, being that we just did whole exome sequencing on the patient, is whether those mutations are in cis or in trans. So in looking at COG6 deficiency, there's not much reported about it, and the phenotype is very varied. So the clinical features include developmental delay, which our patient is certainly delayed, but it's hard to know whether that is secondary to him being hospitalized for all his life or whether this is just a developmental delay that was going to happen regardless. He is microcephalic. He doesn't have any facial dysmorphisms. He is hypotonic, but again, he's been critically ill the rest of his life, for all his life. Also, liver involvement is an issue. Our patient had intermittently elevated LFTs, but this was attributed to TPN. He has no evidence of cerebral atrophy or recurrent infections, skeletal abnormalities, or epilepsy. Hypothermia is also seen with COG6 deficiency, and our patient does have this episodes of fever. So you could say that maybe this is more hyperthermia driven, and he does have a history of thrombocytopenia and obviously GI issues. So as far as COG6 deficiency goes, certainly fits some of his clinical picture. So additional workup that we've done, we've obtained maternal COG6 sequencing, and she has one of the variants. It still doesn't answer whether the patient has the variant that he inherited from mom and then a de novo variant in the same allele, making them in cis, or whether this is true in trans. And he's a compound heterozygous for this variant. We obtained expanded whole exome sequencing, and it didn't really provide any additional information. We tested for carbohydrate deficient transferrin, and that was normal, not consistent with congenital glycosylation disorders. And then we repeated FOXP3 expression that was consistent with prior results. And then ultimately his anti-enterocyte antibody became positive, or resulted positive. So when we got the whole exome sequences result back, we thought, are we treating the right disease? We have been given this child immunosuppression for this presumed IPEX syndrome, and maybe that's not something that he needs. However, shortly after stopping sirolimus, his white count became very highly elevated into the 120,000. He became febrile. His stool output, while not shown in the graph, ultimately worsened, and the amount of blood in his stool worsened. So he was restarted in immunosuppression with improvement, and he defervesced. So just to summarize the case, what we have is a 4-month-old male with profuse bloody diarrhea, TPN dependence, hemolytic anemia, leukocytosis, hypothyroidism, and intermittent fevers without an infectious source. Low FOXP3 expression with normal FOXP3 sequencing, and then 2 variants of unknown significance in COG6, but normal glycosylation, with poor weight gain despite immunosuppression. So the questions that I have are any additional workup or management recommendations, and given what we know now, is this a patient that should get bone marrow transplant?
So Naty, one question came, and maybe Dr. Torgerson could help us with that as well. What other causes could explain this absence of FOXP3 other than what we thought about, since nothing on the genetic testing?
Yeah, so what I've certainly been trying to read about is just regulation of FOXP3 expression, which I'm sure Dr. Torgerson can tell us much more about.
Well, no, I was just, I think the first thing you need to, as we sort of chatted a little bit beforehand, but I think the first thing you have to do is look for the obvious things, which is other defects in the FOXP3 locus. I noticed that somebody just put up that maybe a search for intronic mutations, which I think, everything clinically here really points to a picture, I think, of IPEX. He's more IPEX-y than most patients. I mean, he really looks quite classic for IPEX, and he's the right gender, he's got the super high IgE, the biopsies look certainly suspicious, and his response to immunosuppression certainly seems to correlate as well. And I think, we've now found 4 families who have mutations in the polyadenylation signal sequence of the gene. So the sequence of the gene is normal, but when they make messenger RNA, it doesn't get polyadenylated, so it just gets all rapidly degraded. And so, and most people don't look at that region of the gene, and there's probably mutations in all of the genes that we think about out in that region that just get missed. And I know that you guys, Naty, you can actually, I know you've got hot burning news on that one to give an answer to that one. And then the other place would be to look, certainly for deep intronic mutations that lead to splicing defects, any, copy number variants, those sorts of things that you would maybe miss on traditional either exome or Sanger sequencing. And there I think the most straightforward thing to do would be to just sequence the cDNA and see if you've got a splicing variant that's abnormal. And like I said, the other thing you can do is you can take the patient's T cells, you can activate them, and then do flow for FOXP3. And if there's a splicing variant that makes it so that no protein can be made, you won't see any protein. If, however, if they can make protein, if it's a mild defect, then you'll see protein being made in some of the T cells after they're activated. So, those would be sort of things to sort of interrogate the FOXP3 locus more. So, and Naty, you can respond to that, at least to one of those. I know you've got hot new data.
Yeah, so we just got a report back that in sequencing, including the polyadenylation signal, that is normal. So that doesn't seem to be the case. The one question that I have is that despite his very elevated white count, his lymphocyte count is so low that has made any additional interrogation of his T cells very difficult. Is that something that is typically seen in IPEX? Or is this all sirolimus driven? So for example, yesterday his white count was 60,000 and he had 0 lymphocytes being reported.
Yeah. And it's not classic for IPEX, and it does raise questions about other things. I mean, there's other things that can look like this. Leaky skid patients can look very IPEX-y with high IgEs and gut disease and skin disease and those sorts of things. I think you have to keep your mind open about those sorts of things. So, unfortunately, the exome sequencing was, unfortunately negative for all of those. So it makes it very, very difficult.
So Naty got a couple questions. One of them was spectrotyping done?
We did not. And if somebody could educate me, I'm not very familiar with what spectrotyping is or what it looks for.
Kelly, do you want to make a comment on that?
Yeah, go ahead. Kelly commented.
Oh,
so
yeah,
looking,
sorry.
Kelly's point was looking for oligoclonal T cells.
Yeah. Sorry, when he's talking about the omens or skid, or the leaky skids, I guess that's what I was talking about, or posting about too, the oligoclonal T cells. That's what I was referring to.
But
then I take it back. We did do it and it was negative.
I was going to say, the hard part with that assay is that if you don't have very many lymphocytes to test, depending on how you do it, it can look like it's got a limited repertoire. So that test is a little bit challenging when you don't have very many lymphocytes, so I think you have to interpret that. But if you saw, even with a few lymphocytes, if you saw a broader spectrotype, that would be reassuring.
Mm-hmm.
And I think the one question was about antibodies for celiac disease. I believe, Naty, you've ordered those tests at one point, right?
We've ordered a whole host of autoantibodies, but we have not ordered specifically for celiac. And then I also see here functional antibody testing. It's difficult because he's only 5 months old, so a lot of it is maternal antibody, and he has such significant protein-losing enteropathy requiring daily IVIG that unless we were to do salmonella typhi vaccine or something like that, it would be really challenging to assess.
Naty, I was going to just ask, the question about celiac disease. I mean, have you done HLA typing on him sort of in preparation for a possible transplant? And if so, does he have the HLA types that would put him at risk for celiac disease?
We haven't done HLA typing yet, just because he's been so ill. But so we haven't gone to that yet.
One question about the lymphoproliferative assay for mitogens and antigens in this child.
They were normal in both our lab and then at the outside hospital.
Great. So maybe we should just finish with maybe a comment from Dr. Torgerson about hematopoietic stem cell transplant in this child. Would you proceed?
Yeah, I mean, so I think, this question has been raised about tufting enteropathy. Obviously, if that was the issue, you would not, transplant would not be the path to go. I think, if you can, have your pathologist carefully look at things and, give you some idea about whether there's whether they feel like there's any gut intrinsic defect. If there's not, I think you clearly have evidence that immune suppression actually works in this child, suggesting that possibly affecting something that affects the immune system, the hematopoietic system will be efficacious. So and based on this story, the story and the labs and everything, it certainly seems like on IPEX, even with the negative workup we've gotten so far, I think you've got a little bit more work to do that to rule that out completely. But if it's not that, it's something that's certainly acting very similar. And my bias would be to proceed to transplant. I mean, the problem is he's sick enough that at some point he's going to get some bad infection or something, and he's just he won't make it to transplant. And so I think not that you necessarily want to precipitate his demise. You want to stabilize him, get him as stable as you can be, bulk him up as well as you can with TPN, try and control his inflammation as much as you can, and then my bias would be to go to transplant. Obviously it'll be easier if you've got a good donor, but I think the hard part is that it's going to be difficult to maintain him long term given how ill he has been.
Well, that was a great case. We went a couple of minutes over time, but we had 45 attendees still online, so that speaks to great cases and great discussion. I would like to thank everybody for tuning in today. I'd like to thank Dr. Torgerson and Dr. Abbott for being with us today and for the presenters. And don't forget to submit cases to the webinar. Thank you all and have a great night.